Hi everyone, this is Bashar Qumseya here, and I'm happy to be joined today by my good friends Dr. Sherif Elhanafi and Dr. Mohammad Al-Haddad. They were the first co-authors along with Dr. Nazar Forbes, who could not be with us today. And we're excited to be here at DDW in Chicago, and we decided to do this author interview where we're going to try to explain to you some of the most recent guidelines we have on endoscopic submucosal dissection for esophageal and gastric lesions. Thank you guys for being here.
Thanks, Bashar.
Mohammed, can you tell us why is this an important guideline?
Bashar, as you know, the adoption of ESD has increased significantly in the last 10 years in the US and Northern America. In the past, this wasn't anything that we discussed often because there wasn't much of a need. However, the adoption ever since third space endoscopy took off has increased. And I think we have different practices from the rest of the world. I think it would be a great time now to define how we pursue some of these clinical situations and how we remove some of these lesions in a scientifically driven fashion and improve patient outcomes.
Excellent. Thank you so much, Mohammed. So as we're going to present some cases here, and we'll just talk about how would you do it. A lot of the questions we're going to talk about today, when do you do EMR, when do you do ESD, and when should you do neither of them and maybe send the patient to a surgeon. So we came up with a lot of criteria in our guideline based on size, morphology, ulceration, things like that. So let's start with the first case we're going to present today is a 70-year-old male who comes to you for evaluation of recently diagnosed esophageal squamous cell carcinoma. This was done outside by an endoscopist. A small lesion was identified. They didn't really tell you the size, and they come to you and they're asking you for your opinion. So you are now in open access center, you're doing the endoscopy. And tell us, what are you looking for and how you decide whether to proceed with EMR, ESD, or neither one? We'll start with that.
Thanks, Bashar. This is a fairly common scenario, at least in the practice like ours. We are a large referral center, so we get patients diagnosed with cancer elsewhere sent to us for triaging and staging. And I think the first thing I would like to know about this lesion, Bashar, is obviously location, size, but features and characteristics that may indicate any submucosal involvement or not. This is a key thing in squamous cell carcinoma. As you know, those tend to invade the submucosa fairly quickly, and they also spread to lymph nodes fairly quickly. So that would be the first thing I would want to look at, obviously beyond size, if there are signs of any submucosal invasion. Any submucosal invasion in a squamous cell cancer lesion would make this non-curative by definition, so we have to do our due diligence in identifying those signs. Obviously, those lesions typically fall in the Paris 0 to 2 classification scheme of lesions and are typically associated with, or not associated with any significant ulcerations or any elevated or raised margins, and they typically have either a well or moderately differentiated pathological component. So there's really no tolerance for any lesion that would be either non-differentiated in this case or a deeply ulcerated lesion. In this situation, I would not consider any endoscopic therapy for such a lesion.
Yeah, excellent. Thank you so much, Mohammed. Sharif, this is a bit different from what we're going to talk about the next case, which is Barrett's esophagus. Because frequently with Barrett's esophagus, you might find a lesion and decide to remove it then before taking a biopsy. So you don't have differentiation. Clearly you can tell if it's ulcerated or not. Can you tell us why that is important and why we need to have a biopsy of this lesion before we proceed with endoscopic resection?
Absolutely. So any Barrett esophagus lesions, we have first to rely on endoscopic examination to make sure there is no nodular Barrett's or there is submucosal invasion. And before we decide what we need to do, a histological examination, sometimes it is very important to know the differentiation and the type of the lesion. And based on the histological differentiation and examination, we can decide what will be the next step. So the baseline, if you see nodular Barrett is a little bit forgiving than squamous cell carcinoma. Squamous cell carcinoma is a little bit in aggressive side. But Barrett esophagus, any nodular Barrett can be treated by mucosal resection or ECD, and based on the histological evaluation, will pursue the next treatment modality. And in this situation, if it came as adenocarcinoma, so based on the stage of the adenocarcinoma and the size, we'll decide what will be the next step.
Yeah, very good. So what I'm also trying to get at is if you find a lesion that looks like squamous cell, you need to biopsy that to get differentiation before you can decide how you're going to proceed with resection. Whereas if you're doing a Barrett's examination and you find the nodular area, you're likely going to resect it if it looks resectable, regardless of the differentiation type, unless there is evidence of submucosal invasion. So that's an important distinction. In this guideline, we chose a cutoff of 1.5 centimeters to decide when you would do EMR and when you should not do EMR and proceed to ESD. Can you tell us why this is an important cutoff and how we came up with this cutoff, Mohammad?
Definitely, Bashar. You're referencing here squamous cell. 1.5 was the cutoff that we adopted for squamous cell cancer of the esophagus. When we conducted this systematic review meta-analysis, we looked at the lesion size in the studies that we included, and based on the median lesion size adopted in each group of the papers or the studies we reviewed, we determined that lesions up to 1.5 centimeters in size would generally be associated with more favorable outcomes in terms of resection. And they typically tend to have less risk of submucosal invasion, which would lend typically to a better treatment with ESD. So anything less than 1.5 could be attempted to be removed by EMR. Anything over 1.5 could be attempted or should probably be referred to as ESD. And I think this should be attempted ahead of surgery. We discovered that for those smaller lesions, the risk or the complications, adverse events from surgery definitely outweigh any potential benefit in the smaller range lesions like the ones we're talking about.
Excellent. There is a good likelihood also of removing them en bloc if they are small lesions by EMR. Whereas if they are more than 1.5 centimeters,
it is difficult to
unlikely
to get en bloc resection.
All right, so in this particular patient that we said, they come in, you find a well-differentiated lesion on outside pathology. There's no ulceration in your examination, no overt sign of submucosal invasion. It's about maybe 2 centimeters in size. You decide to proceed with ESD. Sherif, you do ESD, and you get curative resection. Can you tell us what curative resection means and what would be your next steps?
So curative resection means you remove the lesion entirely and block in one piece, and there is no invasion to the deep margin or to the lateral margins, with no lymphovascular invasion. So once you get the specimen out and send out for pathology and it is curative, patient can go for surveillance, go into surveillance program, which need close follow-up at the first year with endoscopic evaluation every 3 to 6 months, and for the first year, then every 6 months for the second year. And if you didn't get curative resection, you here will have to refer for further discussion, approach it in multidisciplinary approach, discuss with the surgeons and with the oncology team, and based on the patient fitness for surgery and his condition, will pursue the further treatment, either go again for ECD or go for surgical treatment or palliative chemotherapy. So the specimen will determine what will be the next step.
Excellent. Very good. So you have curative resection, they're going to go some sort of surveillance, which we delineate here. Non-curative, we're going to discuss them in a multidisciplinary fashion. The same thing if patients come back and on surveillance and they have recurrence, then again, a multidisciplinary discussion is needed as should you do further ESD, or should you offer surgery, or in discussion with the patient as well. Excellent. So let's talk about, we kind of mentioned it already a little bit, patients with Barrett's esophagus who are suspected of having nodular areas or adenocarcinoma, and how you would treat them. Sherif, what things are you looking for specifically and how would you decide when to proceed with EMR and when to proceed with ESD?
So first, as we said, we do good endoscopic examination at the initial endoscopy, and any nodular parrot should be treated as per ACG guideline for parrot esophagus. And then if there is a adenocarcinoma, we determine that 2 centimeter is a cut-off, which can help direct us either ECD or EMR. So if it is less than 2 centimeter, you can still do EMR or ECD if the lesion is not ulcerated or no signs of submucosal invasion. But if the lesion is more than 2 centimeter, we recommend ECD more than EMR, because the chances of en-bloc resection will be higher with ECD and get the lesion totally out.
Very good. And in our guideline, we document why ESD has better outcomes in terms of survival, recurrence. There were many outcomes that we looked at, and we encourage you to go read about why we made this recommendation. So obviously, somebody who has overt signs of deep submucosal invasion, just like we said with the other one, we're going to send them to a multidisciplinary board. Okay, so Mohammed, you do ESDs. A patient comes to you, has a 3 centimeter lesion. You decide to resect it by ESD. You resect it, and again, tell us about curative resection versus non-curative, and how would you deal with those?
Definitely. So the key thing with en-bloc resection, curative resection, is to get a very good pathological assessment of the specimen. And I say that because the major determinant in the next steps would be whether or not there is submucosal invasion, and whether or not that is still within the curative resection criteria. Typically, the top third of submucosal, or 500 micrometers, would be the limit that we can tolerate for curative resection. If there is submucosal invasion, then obviously the surveillance would be more intense. You're looking at every 3 to 6 months for the first year, so several endoscopies in the first year, and then twice a year in the second year. And we also recommend considering imaging with EUS or with CAT scan up to 5 years, at a minimum 3 years, if they have any submucosal invasive component. If they don't have submucosal invasion, I think the surveillance can be relaxed a little bit, still looking at least 2 endoscopies in the first year after ESD, and then annually from that point on, depending on the overall risk. As you know, in Barrett's esophagus, there could be new lesions developing over time, so ongoing surveillance is necessary even beyond the window of time that we specified.
And a big distinction here between the squamous cell and the adenocarcinoma is that in addition to the ESD or EMR that we've done, we're going to now continue to do ablation and the goal of to have complete remission of intestinal metaplasia and complete remission of dysplasia. And after that, the surveillance will kick in. Yeah, will kick in. All right, excellent. So the last case we want to talk about here is gastric lesions that are suspicious for early adenocarcinomas. We wanted in this guideline to make this clear. So there are 4 criteria in assessing patients who have gastric early adenocarcinoma, which include size. Can you tell us about this criteria, Sherif,
Sure.
and what we're looking for specifically?
Sure. As we said, there is endoscopic evaluation is very important, and you have to look for ulceration if it is present or not present. The size of the lesion, if it is less than 2 to 3 or more than 3, or the histopathology of the lesion, if it is well differentiated to moderate differentiated to poorly differentiated, or the type of the lesion, of the histology, if it is intestinal or non-intestinal pathology. So this is the 4 main things: the differentiation, the type of the pathology, and the size, and the ulceration, presence or not presence of ulceration.
Every time you have a patient with a gastric lesion, suspected adenocarcinoma, you need to have these 4 criteria.
Exactly.
And Mohammed, what specifically within this criteria would you not do ESD for? Would you send them to surgeon?
Of course, any non-differentiated pathological component, diffuse type, so the non-intestinal type, should be also sent to surgery, or at least discussed in a multidisciplinary fashion. Now, the ulceration itself is not an absolute criterion for kicking out of the endoscopy treatment modality. I think if there's any ulceration present that's still potentially eligible for ESD, I probably would not offer EMR to an ulcerated lesion, especially a lesion over 2 centimeters in size. I would definitely err on the side of providing ESD as an ultimate treatment modality for these lesions. Obviously, still respecting the fact that it has to be of the intestinal type and has to be well to moderately differentiated.
Exactly. So first we look at the differentiation and the type. If they are well differentiated to moderately differentiated, as you said, or intestinal type, then we're considering ESD or EMR if it's a very small lesion.
Correct.
If it's otherwise, then we have to discuss this for surgical evaluation first. So patient comes in, the biopsy shows, well differentiated adenocarcinoma, intestinal type, and no ulceration. And then you're really depending on the size, right? What size cutoffs did we decide here on?
So we said less than 2 centimeter, less or equal than 2 centimeter, and if the lesion qualify for other criteria, can go for EMR or ECD. Size from 2 to 3 centimeter, we prefer ECD more than EMR. More than 3 centimeter, I think this patient should be referred for surgery or multidisciplinary discussion.
Excellent, excellent. And similar to what we've talked about before, now you perform the ESD, you're looking at curative resection, and if you do achieve curative resection, you're going to put them in a surveillance interval, which is different if they have T1B or submucosal invasion or high-grade dysplasia versus T1A. Then you're going to have surveillance. You want to tell us more about that, Mohammad?
Correct. So anything T1 high-grade dysplasia or T1A, so no submucosal invasion, should probably be surveyed with endoscopy twice in the first year, so every 6 months, and then you carry this on for 3 years, and then annually. Again, these patients are at risk of multifocal recurrences, not necessarily at the site because of the underlying field defect that we know in gastric cancer. If they have submucosal invasion, that obviously takes the surveillance to a higher level, especially in the first few years. So in the first year, I would do exams every 3, at the latest, up to 6, but preferably closer to the 3 to 4 month window of interval for the first year. Then you can relax that to every 6 to 12 months in the second year. However, I would add the component of imaging if they have submucosal invasion. Again, those are the lesions we've noticed they tend to recur. So you'd like to add either ideally a CT scan or maybe an endoscopic ultrasound. I favor a CT scan in this case for up to 3 to 5 years if there's a submucosal invasive component.
Excellent. And just like we said before, if you detect recurrence, then you're going to send them to a multidisciplinary board to have a discussion.
I may add that recurrences actually, according to the literature we reviewed, can be dealt with endoscopically, and actually more so with ESD than EMR, can be removed with ESD. Due to the fibrosis that you might encounter after initial resection, EMR may not be the best modality for recurrences.
Yes, which also is the case for esophageal adenocarcinoma. Correct. If you started with EMR, you could potentially switch them for ESD for recurrence. So, these guidelines have a lot of commonalities. Basically, you're looking at the morphology, we're looking at signs of submucosal invasion, we're looking at size criteria. We said for squamous cell, we are gonna, it's more aggressive, so we're gonna take a 1.5 centimeter cutoff. For adenocarcinoma and Barrett's esophagus, we said, okay, let's use a 2 centimeter cutoff based on the data. So those are some of the differences. And for gastric lesions, again, the 2 centimeter cutoff for EMR and ESD. But if it's more than 3 centimeters, then probably you need to consider surgical evaluation if possible. So curative resections for any of them, they're going to undergo surveillance. In Barrett's, they're also going to go eradication therapy. If not curative resection, a lot of times you're going to go into a tumor board or multidisciplinary fashion, and more invasion they have, maybe T1B, then they are more likely to have closer surveillance. So I think this summarizes what we have found. We also are working on a guideline for lower, for colon ESD, which should be coming up. I think I want to thank both of you for being here today, but also for undertaking this tremendous effort. This was not an easy document. It was a difficult document to deal with because this is the first time that we had to do this in the US. And I think our guideline is going to give some clear recommendations for practicing endoscopists, what to look for, when to do EMR, when to do ESD. Our guidelines are never a substitute for what an endoscopist should do. And of course, always make sure that you have a discussion with the patient, because patients' values and preferences, we try to consider those here. There was not a lot of data. We did have a patient advocate on the panel as well. But most importantly, to talk to your patient and make sure they are on board with this plan. Any last?
No, thank you, Bashar, for guiding us through this. As you pointed out, very difficult document. It took us 3 years of hard work and a lot of involvement from other committee members as well. But thank you for your guidance and your leadership, and we appreciate pushing this to the finish line for our colleagues and for the ASGE community at large.
Yeah, thanks Bashar and Mo for. It was honor working with you, also with Nauzer and all the other SOP members. It was a great process, and as you said, we have the committee has worked on 3 well-delineated algorithms to guide clinicians through this decision-making process. We hope that this will help them and guide them in their decision to treat these complex cases.
Thank you guys so much, and we appreciate it. Please stay tuned for more author interviews about our guidelines, and take good care of your patients. Thank you.